September. So we did a total of, I think, 11 days last year. 3 in March, we did 3 in November, and then 5 in December.
Yep.
And just with like, what are we trying to do, or what's the, because I think some of us, particularly the newer folks, there's kind of a different approach or a different maybe culture or a change that we're kind of moving towards or hoping to move towards. So are there questions about things or things that...
Like I don't know how they feel.
Yeah.
I kind of tried to watch really close. It really, like, you know, the block meetings, and
Yeah.
they're not privy to that.
No, that's-
tried,
yeah.
Taj and I try to tell them everything,
Yeah.
but we forget things.
Yeah.
But I think on our end, and you guys can speak, I think the blocks went really well. So we had shoulders that came out extremely comfortable.
Yeah.
And of course, we didn't have to do the narcotic and all those things. Some of the questions we have, Scott, are, I think some of the staff want to know exactly what we should tell 5 North on report.
Yes,
about,
yes, yeah.
Like, what do you want us
Sure,
to say about
sure.
the little hookup,
Yeah.
right?
Well, and the other thing too
Yeah.
that I was thinking about, I hadn't written down, is what's going to be in the order sets for the nurses on 5 North,
Right.
6 South.
Yeah.
Like when you're doing tap blocks or different types of
Yeah.
blocks, like,
Yeah.
because they need. What I've heard back from some of the people I've worked with on 5 North is it's great because they come there, but sometimes the communication, there's some gaps.
Yes.
I can tell that frontline nurse in report, but she may be so harried by the end of her shift that she doesn't pass it on to the
get
next,
passed
and
along.
then they lose. There's big gaps in
Yeah,
what
absolutely.
they know to
Marker.
look for.
all good.
Yeah.
It's all good.
Yeah, so I guess even pulling back, so in most centers, regional anesthesia is very dominant. They do lots. And you're seeing some of the advantages as to why. Coming here, there's always pockets where it's very cultural, because like where you train, you often go work there. So UBC historically was not a big hotbed of regional anesthesia. So interior BC, not so much of a hotbed. And Kelowna, when I went there, so when I moved here, the plan was to go work in Kelowna, and I show up, and the very first thing they tell me is, don't do regional, don't do blocks here. Pisses off the surgeons, they get very unhappy. We've had locums come, they start fights. And I'm like, whoa, okay. Sure, but it's just a tool. It's like saying, don't do a spinal, don't do a general.
Yeah.
It's like, these are tools. We can have conversations around like, why this person, and it's funny, in the 3 weeks that I was there locuming, we'd have patients, chronic opioids, the whole deal. And I just go to the surgeon and say, there's something I can do here, or we can just kind of let it go. And then they would say, oh, no, go ahead. And so it was this really weird dynamic of like, it's not that they don't want it at all, but they want to really kind of control how it goes forward. And that's okay, but it puts kind of a real stigma. And so coming here, there was more openness, but it was still like, we don't do a lot of it, and it's okay. But like, I think you've seen, we've kind of shifted that a little bit, where now there's still, I'm working with Outerbridge, and I'm working on these guys to try to like, but there's some, like Scott Hughes was an early adopter. He's like, great, anything that helps my patients and lets them leave hospital sooner, patients want it. How do I help you? So that's why we did a PQI project with shoulders, because it's like low-hanging fruit. Shoulders for sure. They hurt a lot. Most of them could go home same day, even the total shoulders, if we get their pain under control. And the overlap of shoulder pain plus OSA, we see it, right? It's like 60%. So that group does terribly with pain, opioids. Whereas if you can do a block, their risk for sleep apnea is actually better at home, because they come here and they're in a room with beeping or daycare extended. You go see them the next day and like, oh yeah, I didn't sleep last night. Like, well, that's not good. You're gonna go home now more tired. Your likelihood of having a bad second day, I should actually keep you in hospital another day if you don't sleep the first day, because you're gonna have like REM rebound. You're gonna be in a deeper plane. If you miss sleep, that night when you do get to sleep, you go like boom. So it's like, really, I should send you home on the first day and then have you come back to be admitted on the second day. But anyway, so that was the kind of thinking around like, okay, how do we shift the culture a little bit? And the problems are always like time. Surgeons always have to think of it. Like, I don't want my room to get canceled or delays. You're gonna do these blocks, no one's gonna follow up on them. If we do a block, usually they're only about 18 hours. So, okay, what happens at that point? If the patient's gone home and now the block wears off and having a lot of pain, who do they call? What do we do? So that enters the catheter piece, where we can now shove those blocks out 60 to 72 hours, depending on when we start the infusion. And that seems to really help, because when those blocks wear off on day 3, patients are much more comfortable. It's not like the 18-hour where the block wears off and they get so much pain. So how to do that? And the challenge with the timing, for those of us who've done it a lot, Prince Lou can do a block in 7 minutes. I can do them very quickly, Olu. But for those that are like interested, even Mark, but just don't want to feel rushed with time, or like the Lisas and the folks who are like, look, I would do this, but I want an environment where I don't feel like someone's looking down my shoulder. So enter the block room. And so the primary goal of the block room is just to get more regional anesthesia. That's its primary goal. Everything else is a side benefit that we use to kind of say, okay, well, here's how the business case could look like. We could do spinals, we've done spinals. We don't have to. None of those are mandatory. The key thing is we get the regional anesthesia to happen for more patients. And it doesn't mean they have to have only a block, just it's a way to have the block happen and now they're ready. And so the room can go in and it can be business as usual with minimal perturbation, and everything else becomes a side benefit. Like their care should be easier in PAR if the block's working.
It's better in the OR, Tracy Shepherd was saying.
It should be easier in surgical daycare, it should be easier at home. All of that should be, it shouldn't be a adding work to anybody, but it's a change. That does add work, and as we figure that out. So we haven't mastered this by any means, and every site that tries to do it, whether it wins or loses, they always have to adapt it in some way. So they stop doing spinals because maybe that's causing too much confliction and timing problems. So that's one of the ways. Some sites just give up. They just like, well, we can't do this. But I came from a place that was the same size as us, so I know, and we were able to do it there, so I know we can do it. But figuring out what's the right thing.
Yeah.
To your point about changing the order set so people know what's happening, we started trying to do that a year ago. And what we've fallen victim to is IH has a territory-wide mandate for changing things right now. They want everything to be standardized, and Kelowna doesn't want to do this, and Ticton doesn't really need to do this. Vernon is curious, so we're working through it. We tried to make changes to an existing one, which you used to be allowed to do. That was kind of a loophole, and then they kind of closed that on us. So there's a little back and forth. So in the meantime, we're not, well, for the most part, not running infusions until they leave. There's a little caveat there. Occasionally we do break that, but generally speaking, there's not. So the instructions are just that they have a catheter. Contact us if there's pain. They can call the anesthesiologist on call. They'll get through to whoever did the block, that kind of piece.
Is that in their order set?
It's not in
an
the
order set.
No.
Is it in a message to nursing or something?
It's the message so this is, your point is perfect. I give that message to the first nurse I see, but I'm not necessarily seeing
And I think
shift
that's where
change
some
nurse.
Of the, you're finding some of the breaks
Yes.
in communication.
Could we put it in a message to nursing?
I don't see why
On
not.
the
We put
computer?
everything
Right?
else in it.
Yeah.
Like maybe
Where
that'll
does
help.
that, just if someone could show me, I've done it, but I haven't done it recently. I think I've probably forgotten how.
So it's pretty easy. It's
You
right
show me.
under. It's right under order set. I don't know what we can bring up here, Taj. Can we just pop somebody up?
Oh, yeah.
I mean, I could bring anybody up, I
Yeah.
guess. Really, honestly. Because our screen looks like yours now, which is super
Yeah,
bright.
this helps.
Yeah.
Yeah, our
that's
screen
one of
looks
the
like
changes.
theirs.
So the long-term plan is there'll be a pain service. We put a proposal in 2 years ago. There'll be nurses. You heard that spiel from me. So that will be they'll round multiple times. There'll be nurse education, the whole piece. That is waiting on a funding decision, which I think now has been kicked down to May or June of this year now, 2025. So we hope to hear in this late spring.
Yeah, but everything in healthcare moves at a very snail pace.
Well, and that's
so
what they're finding.
It's
Yeah.
kind of
Yeah.
trying to.
I think
Yeah, I think-
2022 we first put the proposal in, and we had to refine it, but certainly by 2023 we had a proposal in.
So we got to go to orders.
Yeah.
Scott, would that be with nurse practitioners?
No,
Okay.
so my experience is using nurse practitioners, but there's not a clear model in
Right.
BC for that.
Right,
So
okay.
nurses-
Could be anyone.
That's who-
Enter.
DC2.
Yes, yeah,
Yeah,
that's
If you
right.
want
Yeah.
to
So you
do
guys,
order.
right?
Yeah, that's
So,
right, yeah.
uh,
Yeah, I
other-
don't-
And honestly, our nurses are ideal. Like,
Yeah,
this
they
is
know.
all within your skill
Yeah.
set, and so it's just a few
So just
changes
put
to
his
like,
name in.
Yeah.
okay, what do we do with catheters? And
Right.
So there's an education piece. The
You're
other
just
thing I
not
do,
going to save it.
I give a education piece to the patient that has my phone number on it. It's at the bedside. And it's like, call me.
Yeah.
Say it's verbal, Scott,
Yeah.
and then you of course go through all this,
Okay.
And then save.
and then we go to
Sorry, I missed where you got
No,
this from.
she's-
Though. Oh, okay.
just your regular
Oh,
order.
just under
So
orders
you're
you
just
go
gonna put
message?
Just do message.
Message. Okay. Perfect.
And then you can do a lookup, and it'll be message to nursing right here.
Sure. Yep.
And
you
you
want it
always do-
ongoing.
I
Just
will,
do now.
No. Do ongoing,
Ongoing?
so it follows through
Oh, to the
to the
floor.
floor.
Okay.
Because it's the floor we're
Yeah.
worried about, right?
Yeah. What we've
And it's a
I'll
free
talk to you guys.
test.
This seems perfect. If you close out of this for just a second, we've been using. There's these sticky notes. Have you seen them when?
Okay, you
No,
show
I
us,
haven't
Scott.
seen
You sit down.
I don't
and
know
show
where they. Yeah. Have you seen those? So when your list of patients comes up here, there'll be these yellow. They look exactly like Post-it notes that you can free text.
Oh, I've never seen that.
No, I don't know.
So when, yeah.
Oh,
There's the comments. It's like how
Oh.
emergency use your little comments.
And this is
Right,
this
right.
is
The
instant.
status
Like you
board.
can whatever.
So
15
that-
pages.
that'll work.
And so I just go to the top. So I've been doing that, but I don't know if you. I don't know if you're seeing
you
this.
see it.
Yes.
So a lot of
I
us
don't-
just
I don't think
Yeah.
a lot of us
So
see
the
it.
surgeons see it, and the internists and those folks see it, because I
but
know
not
it comes
the
up under their
nurses.
rounding list. They'll have this here. You
But
guys
I
don't
don't
see
think
it.
we won't see
Yeah.
it.
So that's a good takeaway for
So
me.
message to nursing. I know
Message to nursing. Okay.
Eris uses that thing right
Yeah, yeah.
Yeah,
I'll
he
make a-
uses it all the time. And
Okay.
that way you can put exactly
What
what you
you
want to
want.
look for
Yes.
and
And
to
follows.
remind
Yeah.
Right.
And
patients and
with these
families.
things, there's really not, like, the fact that we send people home with it, it doesn't require
Yeah.
any special
No.
care or treatment. The only concerning times are when the catheter is being loaded. If you were to put, so always check to make sure it hasn't migrated intravascular. And the amount we give is so low that it wouldn't cause local anesthetic toxicity almost ever. Any block, there's maybe a couple where there's a potential. So we take that into account. So that's the only like concerning time is when you bolus a catheter. So an infusion
Yeah.
runs just like epidural, slow and steady. Really no issue there, nothing different to do. The one thing to think about is falls for lower limb blocks. So if you do femoral nerve block, that like the quad muscles are going to be weak, the patient may not be able to post well. So that's the piece where when we do those, we definitely need to do this and have clear, like, patient can't ambulate until they can sit, post, holding on to something, first few steps. And I tell the patient it directly, but I can see how it's getting missed
Yes.
down the line. So.
And you know, thinking back to being a patient before post-surgery or even pre, I still only retain maybe
Yes,
25%
Yeah, the
of
verbal
what
stuff.
I was told.
Yep, that's true.
And that was even before an anesthetic.
Right.
Yeah.
Right.
No.
Because you're
Exactly.
so nervous.
Yes,
Yeah.
there's a lot of stress.
So-
A lot of
Yep.
stress. Yeah.
Yeah.
Yeah, for sure. Fair enough.
So with, okay, we're just gonna go on the assumption that this block room is happening. It's gonna happen.
It's going to happen at some
I hope-
point,
I
and
hope
it may
it
be
does.
targeted. It may only happen on Scott.
So-
Like the big, we're short our numbers by a
Yeah.
lot, so it's very hard for us to pull someone out of the OR and put them there.
Okay, so with the block room happening and the recent trial of the flex room, having the two orthopods kind of jump back and forth. How is that gonna affect the block room and our staffing? Like, right
Yeah,
now it
so
takes one nurse
the two
to
things,
do the
the
block.
intention of the flex room is actually not to have ortho in there, it's to try to address general surgical or non-emergency late patients, but there are select orthopods who may be offered, the term I've heard for it is swing room, so they go between two ORs, so it's only a few people who can really make that work. You need to do cases that are sort of an hour to an hour and a half at most. Otherwise, you're not saving enough time. You save 5 or 10 minutes over the course of the day. Doesn't let you do another case. So for that, if the block room were running, it would help to feed the OR better because those patients now, from a flow standpoint, but we have so many other bottlenecks downstream. Our bed capacity, sometimes it's you guys, sometimes it's surgical daycare, sometimes it's weird stuff like they didn't have enough of the colonizing sticks one day to do the nose. It's like we hit these things where we're like, oh, that's a bottleneck I would not have expected.
Yeah.
So
yeah.
we're a ways from, and so all of this is pilot project. It's trialing it, and the goal is not to show at the outset that we've figured it out. It's actually to figure it out, knowing that there's going to be a whole ton. Like I never would have thought physiotherapist would be a barrier to
Yeah.
patients going home same. Usually, every place I've ever worked, they're like, "Yes, we want people to go home same day. How can we make this happen?" I'm like,
And
okay.
here it was a
Here it's
big
like, no,
blocker.
actually, we can't make it happen. No matter what
Yeah.
you do, Dr. Bonneville, this patient cannot go home today. I'm like,
Don't look at me. I'm not.
and I'm just like,
surprised.
okay, sure. I've just never encountered that
And even the patient
because the
wants
money
to go
for a
home.
bed is like multiple physiotherapist salaries, but it's person power. It's
So
people,
I wonder if
not
we
money.
can. I don't know if
Yeah.
we're looking at those pieces yet, Scott, to actually
Yeah.
prove
That it will
that
work.
this hospital stay versus maybe we need another OT so they can take care of like 2 shoulders in a day or a week.
Yeah, so
Like-
by doing this, we've fed forward these are the time savings, these are the patient benefits, here's what we can do. These are the reasons those don't translate into patients leaving. So Pat Curley's been great about
Yeah, he's amazing.
making the business case, which shows that, so this is what we've saved to this point, but we can't send them home for these reasons,
These
which have nothing
reasons.
to do with this. Ergo, if you'd like these financial savings, we got to address
Right.
pharmacists. We are 7 pharmacists short.
Short.
It's incredible.
They're a huge issue
Yeah.
too.
And so
I'm
we're
just
like,
looking at
so these,
the-
so it's surprising.
This is all old news. to
And
me.
I think it points out, like, when we do these pilots, like, we're not ready to say, okay, yeah, tomorrow we're gonna have the block room run every day. We've got this all. No. If we do it again, it'll be another pilot, and we just are trialing. Like this time, the first couple times we did it, it was just me, then it was Jason McClicker. This last time, one of the changes we made was we sort of opened it up to 4 other people, and to see, okay, well, 2 of us can do it, but can people who haven't worked in a block room or don't do it a lot, can they? And the answer, yes.
And they did great.
They did great, right?
Yeah.
There were the first day, the Monday, as you'd expect. Lynn's first day was kind of shaky, and then it got over the course of the week. It was amazing. By Friday, it was on lock. So it was to take what we could do well and show that, but also what breaks. Where did we cause problems? What didn't work out? What could we do differently?
Well, you know what I'm doing on my end, Scott? I just started this week because Chad wants a breakdown of certain things in here, but I added our wait times. Like Tuesday, for instance, was a smoking day in here. We didn't have a problem. We're 2 nurses short, and we were still on hold 17 hours on our elective day to get our patients out when I'm tallying things out. Like that is profound to me.
So a lot of money.
It's a lot of money.
And it's workload too, right? Like if these people slide through here, slide through there, it's just overall care burden should be
it's
lower.
little things like if we have proper housekeepers, because the floors were waiting 2 hours to get their beds cleaned. So I brought that forward to Chad, and he's going to try to work on that.
None of this is intended to be like make people work harder, make people work faster, be more efficient at the expense of patient. Like it's not. It's just this is a way to get, again, my heart, regional anesthesia. However, these are the other ways that we sort of justify and pay for it, and which of these should unburden the system and which ones are causing problems. Okay, well we'll stop doing that, right? The catheters. Some of the surgeons are like, look, I want to examine the patient afterwards. No problem. I'll put the catheter in. I won't load it. You examine them. Patients have a little bit of pain when they wake up. Then I'll come and bolus the catheter in 5-10 minutes. They're going to be comfortable. Like we can change what we do. I can use short-acting local anesthetic. You're worried about compartment syndrome? No problem. We use short-acting, low-dose local anesthetics. We'll see them a little more frequently. Like we can modify
so our number one
to accommodate most things.
Is a toxicity, but to be honest, you would have already done your main bolus, just like a
toxicity we're going to see when we bolus the catheters.
So like an epidural when they're talking.
Just like an epidural. And again, we tend to give doses that are like, because we take that into account.
So
most toxicity is happening from local infiltration by surgeons, because they're doing 100 mils, but they're using 1/4% diluted. But that's where there have been problems. Most commonly, it's with local infiltration because they just use so much more. And they're not using ultrasound. They're just sort of firing.
What happened with that lidocaine?
Yes, that's right.
I had one with a surgeon that was keen to do intraperitoneal lidocaine or bupivacaine after laparoscopic surgery. So he fired a bunch of like 60 cc's of 1/4%, and it was like a 70-kilogram person, which is technically safe. But it's how fast it gets into your bloodstream. It's like a lot of factors. It isn't
so
just...
you guys are chatting, like I wasn't paying attention to what stuff. You guys are chatting with the surgeons about what you put and what...
Yes, we had a communication page, and the person that I'm particularly telling is the anesthesiologist in the room to say, I've given this much, and I'm always leaving room in case they want to supplement, but they can't go over. And when I'm in the room on the other side, I'm the same. They'll ask me, like, how much can I give? I'm like, well, okay, this person weighs this much. This is what we've given, so this is how much room you have.
Yeah, that's awesome.
Yeah, awesome. So
I think it's just...
So are the bottles being filled and hooked up here in hospital or after on... Like,
well, they're being filled here because I'm doing it or we're doing it right now.
That's still an issue?
Usually hooked up after they... So we tried hooking up a few in hospital, and it wasn't so much a system issue. It was being in bed with monitors and various things on, getting tangled up and tied up. And so we found the easiest thing to do right now is to bolus them again, give them, if they needed, a second dose. And then on the morning, they're going to go home. That's when I fill up a bottle and give it to them. And that way their 60 hours pushes them out even further because we don't start it till the next day.
So when they go home, the feedback you've received from the patients and families, did they find were there any glitches on their end on getting rid of the catheter? Like, how's that process work?
It's been excellent. So we call them each day, the first 3 days until the bottle's empty and they've removed the catheter. I've had 2 weird things. I had one person after shoulder surgery get on a bus to Vancouver. And she said, yeah, it's a little sore. I'm like, you're supposed to stay at home. You're not supposed to be doing things. She's like, well, I'm going to go there with a friend and get a car and we're going to drive back together. I'm like, no. She had total shoulders. Like, so I'm like, okay, so that was a weird one. I've done 150 catheters. That was the first. That same person called me the next day, or I called her. She was combing her hair and combed into the catheter and pulled it out. I went, well, okay. I don't know what I could have done to this, so there's that. We had one come out that we had to have them come back in and we redid. That was on like a Saturday morning I was on. We had one during the block room trial where I think 3 of us ended up doing a block. Prinsloo did one on them the next day. So there's always going to be a few, but the vast majority of problems there's 2 things. The first is patients look at the bottle and the balloon's not shrinking. So they say it's not working. And so they either call me or I call them and say, okay, well, gee, are you having any pain? Well, no. Your fingers numb? Yes.
So little.
It's working, but it's going in at 1 teaspoon an hour, and it's a 300 ml bottle. So the instruction page, I should have brought it. It's in I can bring it back, but it's got pictures of like 12 hours, 24 hours, 36 hours, and there's very little change. And so I tell them, but the number one question I get is, I don't think the balloon's going down. It's okay.
But I'm comfortable.
By the next day, and we did have one where there was a kink, and so they're like, it's kind of wearing off, and we had a look and we could see that it had kinked over. I haven't had much of that. Leaking used to be a big problem, and the kits we use now are like our IVs. So the plastic cannula, when you take the needle out, the cannula is bigger than the needle, so the hole it makes is smaller, and the cannula kind of wedges it open. Or wedges it closed, I guess would be the proper way. So it doesn't tend to leak as much. And the leaking is what gets under the dressing, lifts up the dressing, catheter comes out. So without that, very few problems. We have to watch for nerve injury. The rate of that is said to be about 1 in 5,000, 1 in 10,000 in some studies. Usually presents as catheter comes out, arm is still numb, or leg is still numb. Leg stays numb for the vast majority, 7 days or less. There's like a 1 or 2% that can go out to about a month. And you just keep checking in with them to make sure. Theoretically possible at the time of the block that you're needling and poking on the nerve. So it's ultrasound. That's why we have these nice ultrasounds. And that's why our colleagues who don't do a lot of this are very like, I'll do this, but I want to like have more hands-on and more opportunities. So our late start days, we do block club over there. Been doing that for a little while now. I make models, or
It's
to try to
awesome.
make sure people are getting opportunities to like
Practice
see lots of this,
yep.
practice lots of this, so they don't, the first time they're doing it is not on a patient. I had a pneumothorax during the block room trial with a paravertebral block. It's my first pneumothorax, doing that in 200 blocks. The rate of pneumothorax with paravertebrals is 0.5%. Half to 1%. So there's I'm like, it sucks.
Yeah, that should be
It sucks.
your life,
But it's funny, we were actually talking about this at dinner last night, a bunch of anesthesiologists, and we were saying like, surgeons are quite comfortable to do a procedure that has like a 30% complication rate. Anesthesiologists, we want like 0.
Yeah.
We want 1 in 10,000, right? Unfortunately, this is 0.5 to 1%. It was for breast, and so it's like, required a chest tube, patient stayed in the hospital an extra day. It was a thing, unfortunately, and I just followed her, and she's.
But
I was
it's a
happy.
thing that can happen.
It's a thing that can happen,
be
and so
aware of.
that one we don't do a lot of paravertebrals. We may start doing more with like doing breast things. It's just about how do we slowly,
Right.
And then it's the when something happens, what is the process to get an X-ray, a surgeon involved, anesthesia. It's just a small chest tube, so I could go back to, I haven't done a chest tube in a while, but I could go back to learn to do that if this is going to be a
No,
thing.
like you guys should.
But the general surgeons were like,
Yeah.
quite happy.
Quick,
Yeah,
they
Mr.
usually
Johnston, his
deal with
resident, and they're great.
Yeah.
Yeah, and it's not a full chest; it's just a small little, because it's
Pigtail.
Yeah, pigtail, exactly, because the needle is 18 gauge
Yeah.
or 22 gauge, so it's going to be a small hole in the pleura, but you still feel bad. You
Yeah.
know?
Oh,
The
absolutely.
patient understood, and so,
Well,
so
it's-
that's in terms of complications
it's
or
a
problems.
procedure,
Those are the bulk of them.
Right.
And just make sure people don't fall. That's the big one with the lower limb stuff. I think I touched on. We got to
I think too, which we're learning as well. I know the interscalings, which you guys used to do quite a bit of in
Yeah.
you and Prinsloo and all
And I
that.
think the change will be that we'll start doing more and more catheters for the
Yeah.
interscalings, because again, 18 hours is nice, but then
well,
it
then
wears
they
off.
go into that pain, like you're
Yes,
talking
so
about
you could repeat
Corona.
it. You could do a second, but it's 2 needlings versus 1 needle, and then the catheter in the
I
bottle.
want that
is-
baby bottle if I
Oh,
went
that's.
home.
I'll be honest. That's the number one reason I'm doing this. Is
Yeah.
when my shoulder needs doing,
That's what I want.
that's what I want. This is better care. And this
Take
is,
it out and you don't
perfected
need
by that time.
narcotics.
Yeah.
You don't
Yes.
even know,
Yep.
like
yeah,
that.
patients use so
Feel
much less.
crappy
Yeah.
with-
Yeah,
on
those shoulders are
narcotics.
brutal.
And even it is. And even rotator cuffs. It was
Oh, yeah.
well, they're not as bad, but there's some,
You know what,
there's some people who really do struggle. Yeah.
We hit them really hard in here.
We do.
Yeah.
We
Yep.
hit them hard
Yeah.
because we can't even
No.
touch the pain.
Yeah.
No.
Yeah.
Because all that weight is just always pushing
Yes,
down, right?
yeah.
It's always
It's such
affecting.
a sore
Yeah.
joint.
And I guess to the culture change, the thing we've seen with opioids is opioids are great for rest pain. Like if you hold still and you have severe pain and I give you them enough morphine or hydromorphone, they're comfortable. You wake them up and they say they're pain, they're screaming, and pain as soon as they go to move. And I remember being taught in medical school, we blame the patient, that patient's a whiner, or they say their pain is 10 and 10, but they keep falling asleep. But the actual thinking is, no, if they hold still, they're comfortable, but that's not good
No,
pain. Like
they have
our
to
goal
know.
is not a sleeping comfortable patient, it's a patient moving who's comfortable. And the only things that really do that well are NSAIDs, non-steroidals, or COX-2s, and blocks. Everything else is good for when you don't move, and as soon as you move, the pain comes shooting back.
Right.
Or if you're not sedated.
Yeah.
So it's getting, how do we give them, and it's not, I mean, there have been some people like, oh, 0 opioids is the goal. No, 0 opioids is not the goal. Appropriate, whatever the smallest dose
Right.
compatible with good pain control and minimal side effects. So if I'm moving this way compared to some of my colleagues, I'd like to see us kind of, and that's what other sites have found too. Like they've moved a little bit back from the 80s and 90s where, like, you know the story of Purdue Pharma pushing OxyContin and
Oh, man, we
pain's the
hammered
fifth
them.
vital sign. There's
With
no ceiling to
Percocets.
opioids. Yeah,
That's right, yeah.
just keep increasing the dose. Like, well, no, actually, that's not great pain
No.
control. And
Well, and
you know,
look what
Prinsley
happened.
talks
Look what
about
happened, no, right.
he did
Devastating.
chronic pain for 12 years. He said I prescribed opioids twice in 12 years, like prescriptions.
Really?
So it's like, okay, how do we reduce the burden of 60 tablets of hydromorphone in the community, and the patient doesn't take any of them? It's like, okay, this is a way we can just not prescribe so much. Patients don't need it. It's not
It
sitting
is
in their
right,
medicine
you know.
cabinet.
Printer does baclofen and Indocin.
Would we
he
be
does,
doing
he
that
does
with the
not.
pain
He
service, like the
he
pain
never
pumps,
does
the baclofen
narcotics,
pain
so-
pumps? and
No,
things
so
like
I
that?
think for us, it's very hard to, like, you gotta sort of do what you're good at and what you do consistently. So,
Right.
so the question was about like some of the more
Chronic
advanced
pain.
chronic pain stuff. I
Right.
think we've got guys, and it's possible down the road, but I think acute pain and transitional pain, and that's de-prescribing, getting people off. I think those two areas we could do very well here.
Right.
And then with more resources, but really the big stumbling block are those pain nurses. If we had that in place,
Yeah.
a lot of the education piece, and someone's outside of the OR, so I'm not back there and like,
Right.
I can't come.
But Scott,
we have someone who can.
Realistically, like,
Yeah.
is that going to happen? I heard you want a couple nurse practitioners.
Well, no. So that's the model that I've seen most commonly are
Right.
NPs. That being said, what we asked for were level 2, DC2 nurses. So I think it's within their skill set, and we can kind of tailor what they do. It will happen. It will happen because the cost. I mean, the
I
cost
hope
benefit
so.
is very clearly there. But it's decided yearly. It's a salary thing, so it's easy to get money for a one time. But if you're asking for perpetuity,
Right.
so it's unusual that we don't, for a hospital of our size, that we don't have a proper acute pain
Right,
service
right.
with nursing.
Yeah.
And one of the lenses that we've given to them is, look, we're really short of anesthesia. If I have to pull someone out of the OR
Yes.
to go do pain things, that OR doesn't run. You want that OR to run. In fact, you want more ORs to run.
Yes.
So this is how we multidisciplinary team this.
Right.
And every time I mention, someone's like, oh, I'd like that job. I'm like, yeah, it's actually a really great
Yeah,
job.
it is a
great
You
job.
travel around,
I've
you
done it, actually.
you do the trauma patients, so
Yeah.
chest, rib fractures, sternal fractures.
I did it.
Get them at ICU, you save a ton
Yes,
of money.
yeah.
There's a mortality benefit. Patients
Oh,
that
I
have
bet.
rib fractures who get looked after by a pain service versus non-pain service, they have a survival. They actually live, more likely to survive their
Yeah.
hospital stay versus those who don't. So
Question
That's
on
super
that.
exciting.
Yeah.
I understand that you say that you can't adjust the system to the orders and
Yeah.
tell the floor. What about adding them to that acute pain service docket?
same
problem?
same problem. They don't want order sets to change.
Darn.
We used to be able to modify, which is
Yeah, because like, you
close
keep
that
it in
loop.
there, at least like the floor. can
They
have
want it
this,
to
like,
be
taking
like,
a
we're
couple
actually,
months.
McVicker and I are on a committee. They're trying to have one anesthetic record for all the sites in IH. So that means Kelowna,
Kelowna.
us, Penticton, Cranbrook,
Nice.
Williams Lake. And it's like, come on. Those sites are so different in what they
So
do.
different.
Even, so we have discussions and we're like, yeah, well, we need like a 5 to 6 hour anesthetic record. And other sites are like, we don't do cases more than 2 hours. Like, what do you need
Yes.
6 hours for? Like, well, they do cabbage. We do these vascular
Yes.
things
That's
that go on
right.
and on. And so like, we don't want to use...
Still
Some of
not
your
on-
backs and
They're
stuff
still
that
not
are-
on
yeah.
Meditech.
Yeah, so there's a lot to the like, oh, how do we standardize when
I think you
sites
should
want different things?
standardise between the tertiary centres.
Yeah.
Should standardise between the two that we have in interior health, and then the other
Kelowna's
centres.
not on Meditech yet.
Yeah.
I know.
Amazing. Yep.
Blows me
We're not on
Me too.
Meditech.
What do
We're
you mean
not
they're
fully
not
on
They're not
Meditech
on-
yet.
They didn't do electronic order entry.
But they're not- they're
Yeah,
still
they just have
charting.
chart. Yeah.
I think if they did like the two tertiary centres and then the other sites that don't do major stuff.
I think we'd be further along if they hadn't made that change of like, we're going to standardize. That's held us up a bit, but I think we'll get there. I do.
Yeah, I
The
hope
business
so.
case
Like,
is so clear.
Yes.
It's so clear, and there's a huge need for it.
Yeah.
Right, massive.
Yeah.
There is a
massive.
huge
Yeah.
You know, so in the meantime, I know you guys are like hustling. You're really hustling, and we super appreciate it. I know on behalf of us, every nurse that's worked over there
Yeah.
has had a wonderful day.
I'm glad.
Yeah.
Because I know it can be like Prince Louis Friday was busy. They did, I think,
they
more than
rocked it,
anybody. They
though.
had 18 or something.
Yeah.
So I was a little worried. I'm like, that could have been stressful. But I think he was good.
It was
They were good.
Steph's 5th day.
Yes.
And
Yes.
we worked a lot with
Nailed down by
There's a
them.
lot
And I
to
think
that,
that's
isn't there?
part of it is
Continuity.
it was her 5th day, so she knew.
Who to
Yes.
But
communicate
also,
with.
we
and
worked
all
with
that.
Prinsley
Yeah.
a lot.
Oh yeah,
Like
yeah.
a
But
lot.
he's not
super
even working
efficient.
with
He
you.
really
It's
is.
the-
Yeah.
How to pull the patient in
Yeah.
an appropriate
Yeah.
time,
Yeah.
knowing what kind of preemptively, knowing what
She's
you're
a
gonna
rock
need,
star.
all of the
Yeah,
rest
she was
of
great,
that.
and she had a book. But by like day 2, she started
Yeah,
like,
that's
this
right,
is
yeah.
perfect learnings. Like,
Yeah.
what are we getting out of this?
Yeah, I
What's
gave
the,
it all to Pat,
to
which
make
was
sure that
super
we
good.
don't lose the like, oh yeah, this was better than this. So, next time let's do
Yeah.
So
So,
when is the next time?
this. There is no next time yet. We haven't got a date where there's enough of us that it makes sense, and we recognize that it stresses a lot of. So I'm trying to get this message out that like, hey, I'm not trying to make things go
No.
faster, harder, worse. This should unburden, but we're gonna break a few things each time we try. So let's not try too often. So we don't like morale is a thing, and people are messaging. They're like, oh, we're gonna do this now, and now I don't get breaks. We gotta like, no. That is not the intention. Is the patient is ready when the OR is ready. It doesn't. You come get them. We're not there like knocking on your door saying, hey, I've done a spinal. Here's your patient. Like that's not our intention. So
and it is hard to change some of those minds that don't want to change because
Yeah.
like the resource nation when Tracy Shepard is in the OR theater, she said it was so much easier for me.
yeah.
It was so
Surgeons
much
love it.
better.
You very rarely do something that the surgeon's like,
Yes.
oh yeah, I like this because it frees up time.
That's right,
and
yeah.
They see it, and then for those that look more broadly, like Scott Hughes tells me, people come back. So I've done I think 50 or 60 of his shoulders. They come back and they give him scripts of their hydromorphins. Like, I
wow.
didn't fill this.
Wow.
That's awesome.
And so he's seeing them like at the 3 or 4 week mark, and he says, I've not seen that, and so I'm behind anything where my patients come and they say, all I care about is I want to go home today.
Yeah.
Like I think I can make that happen.
That would be me.
But yeah, me too. My bed's more comfortable. My food is better. Like, if I can go home
My
and
bathroom,
not,
I don't
be
have
all
to
of us,
sleep with
actually.
anybody I don't know.
you know, and the other lens we put out there was at home you never get somebody else's medication. Medication errors like that only happen in hospitals because you're with other people.
That's
Right.
huge.
No one's ever going to give you an injection of a drug you shouldn't have,
Yeah.
and you're home,
No, true.
or almost never. So
But
it's like
then-
there's an error lens. There's
Almost
a,
palliative maybe.
almost. You gotta say almost, right? You never. But like, I'm like,
45%.
that's a lens too, where it's like, okay, these are the benefits of doing this, and one of them is people are at home where they're potentially safer.
Yeah.
See that conversation.
Fantastic.
So I hope
We've had it.
I thank you for. I know change is always hard, and not everybody is at all the meetings. We can't always come to a meeting like. That one during the day, it's at noon, and I'm like, I'm taking care of a patient. I got an earbud,
Yeah,
in,
but
and I'm like,
thank
That
you.
was huge,
Yeah, I'm
huge,
still
yeah.
so
thanking
I know
you
that
for
a
that.
big
Thank you
piece
for
that
that.
we
Thank you.
fail at is we're not at all of the tables.
No,
because we can't.
and it's
be.
hard because you're in rooms like
Yeah.
you were at that TE. But if it wasn't for you, I mean,
Yeah.
Taj and I would have been on our own.
Yeah.
The rest of the
So-
meeting has a very different idea, and you need that one
Yes, you
person.
need
Just
that
like you
person,
guys, it's
yeah.
like you say, no. As I learned about the physios, it's like, no, we can't. Like, oh, okay, well that changes this whole
Yeah.
lens of like go home same day.
Yeah.
You know.
Yeah. No, we
So,
super appreciate
The
it.
total knees, many centers can send 60% of their total knees home same day.
Yeah.
That's very achievable. Now you got to look at geography and think about, okay, do they go home or do they go to a
with
hotel?
a baby
with
bottle
a
block.
with a baby bottle, so a ductal canal catheter and some supplements. So not just unis.
I know they didn't work
Years
here
ago.
though. We did femoral nerve blocks and we hooked them up to our IV pole and they
Yeah.
all ripped out as soon as the patient
Yeah.
walked on.
Lots
Yeah,
have
but
changed because that's
lots
where I
has
started too.
changed.
Yeah.
Introduction, right?
But
was.
we used to do them years ago,
Yeah.
And
Scott.
Yeah.
it really lowered their narcotics.
It
Yeah.
did.
Would we ever
Sure.
go to the CAD through CAD pumping?
Yes, so that's the inpatient piece that I'd love. Our epidural pumps can do infusions, even boluses or patient demand boluses, through our these various catheters, and we actually have done a few, but the order sets don't reflect it. It's a thing. So I'm trying because that would be ideal for inpatients rather than the
Yes.
bottles. Is you use those pumps, and then when it's time to go home, we save our bottles for that.
Right.
Bottles cost about $30-ish empty, and then we fill them with about $30 worth of drug and saline or dextrose.
It's a lot of work for you guys.
It takes about
then.
10 to 15 minutes to fill it. A pharmacist should really be doing
Yeah.
it.
Yes.
But if you had an acute pain center,
No,
then
yes.
nurse could do it.
Yes,
They could,
exactly.
absolutely. Nurses can be trained to do this.
Fix that problem, yeah.
The other piece is we can buy them pre-filled for around $120 or so. We just don't want to throw stuff away
Right.
yet.
No.
Right.
So we haven't gone pre-filled don't last as long. They're
Right.
Yeah.
3 months, I think.
Right.
And they have to be ordered through pharmacy, I
Yeah,
found.
they have a
out.
drug in them, and
Yeah.
so therefore it's a thing. Whereas the empty ones we
Yeah.
fill. So there's, efficiencies down the road. But
Right.
for right now, we're still at the like, should these people be rounded on multiple times? Absolutely. How do we do that? Well, that's a little harder.
Yeah,
So,
when you're so
with
short and busy.
With the acute pain services that you've seen in the past, do they have people on call, like for nights, or?
yeah, so the nights are handled by the on-call anesthesiologist. So the days, and the goal is to have everything be on, kind of like the way ICU runs. It should be by 5 o'clock or so, things should be kind of cruise control. I think stuff can happen, but the volume of that stuff is usually pretty low. So the first or second call anesthesia should be able to manage most things. And then by the morning, nurses are back, regular staff is back. And then ideally they have one person, either the block room guy or me, clinic guy, whoever, they can touch base with to say, hey, this is going on, do you mind? Can you come see this, or what do you think about this? And so we can do a lot, just call me. Like, okay, yeah, that sounds great, go ahead and do that, or, you know. So there's a way to make it work, and it's been done like that.
So when the patient comes in and you're looking to do a block, have they been has a pre-conversation occurred with them before they actually get into the
Yeah,
hospital?
mostly no. The shoulders, yes. Scott Hughes has started saying to patients, giving them a little blurb. And during the block room trial, I was calling people ahead to say, hey.
He called everybody.
On my day, I called
Just-
everybody.
Just
But
so that they could
yeah,
actually
offered
think
to
about
them.
it?
Yes. And now the downstream goal is for that to actually begin when pre-surgical screening gets the
Yeah,
patient.
I was
Because
just
there
gonna
are
say that
factors
we're
on
trying to get that in
Yeah, there are factors that would let me say, like, this person's chronically on opioids, they're young, they're having a pretty major, like, ACLs, like, that's probably somebody who should at least have a conversation and say, hey, this is something we could do for you on the day of surgery, think about it, you know, and when they come in, it's a much shorter conversation and a much less stressful thing to say, like,
Yeah,
hi.
it would ideally it would.
Yeah, exactly,
yes,
I agree,
that's right,
yeah.
So that is one of the end goals.
That's
as
one of the
well
end
in
goals
most
for sure.
cases.
Wes. A well-running system, patients should know as far ahead. It's like epidurals in labor. This should have been a conversation, you know, months ago, not today.
Right.
Right. Yeah. But there'll always be a few too, like rescue blocks. The other lens for this is the ability to rescue people over here. So we've done, I think, more than a few on this side where it's like, oh, we didn't think we needed a block. They're really hurting. We're not getting where we want to be. So it'd be nice to very reliably be able to go tap on this guy's shoulder over here and say, hey, do you have a second to do this? Or the person in the room, whoever's going to do it, but just, you know, they're here. It's so close to there. And it's kind of why we didn't want the block room to be over in surgical daycare. Like, it makes sense to be in
100%.
proximity to the
Well,
OR.
I do kind of like it in here. Maybe
Yeah.
going
Yeah.
forward, Scott, when ACU leaves, you can have your 24 to 28.
Yeah, that would be a better
That'd be
spot
awesome.
for
Would
it,
that be a
for
better
sure.
spot?
Yeah, I think,
you-
I mean, that
it's
works out great
okay.
because we're away from the hullabaloo a little bit.
Right.
So,
Whatever
yeah.
you guys do.
Yeah, I was very, like, we thought initially here, but we were very
That's
happy when
working
that
pretty
worked
good.
well. Yeah, because there's 4 slots. and-
There, yeah.
But I wouldn't want to do is go further than that. I think.
Yeah.
Find like the flow.
The flow was great. Like, so we said, like, we did 11 days, and then the last block, like, because you get away from it. Like, we did it in March, and then we didn't do anything until November. So there were 3 days in November, whereas maybe a little bit.
Right.
It wasn't bad. It was Jason and I, so it was pretty, but it wasn't as smooth as it could have been. And then in December, Monday was it was Lynn's first time, but by like Tuesday, I think was Olu. I was Wednesday, then it was George, who's never really done a block room, and I wanted to give him the opportunity so that we had lots of people experiencing it. And by Friday, it was like on lock.
Slick.
Yeah.
And we have to remember the building was at 134% when
Yeah.
we ran this block
And there
room.
were, what, 12 ORs
Yeah.
running? Or
Like
11?
That's right.
12
12
ORs that
ORs,
week,
so
they-
there was a lot.
Honestly,
busy.
there was a lot
And we were
going
just trying
on,
to
and
not
it still
break
was
things.
Yeah,
That's right.
and
badly.
the other huge benefit to this is that patients get out of hospital quicker.
Right.
100%.
So that gives us
So-
more
What
space
was the
for
impact on
patients.
on the
That's the
daycare
part. Okay,
process?
so I know
In getting these people ready in a timely manner to get
that
them here
became
for
an
the
issue.
blocks.
Yeah.
And that is a big, because I know you've spoken to me, and also Jason has as well, about how many patients and Chad, we can put through, we all know. It's our holdups.
If we can
Yesterday,
move our
16
patients,
hours, we
yeah.
waited to get patients out of here.
Yeah.
And daycare is a big block because they put inpatients in there that shouldn't be there, and
Yeah.
all of those things. So
So they can't press, sometimes it's a matter of.
that was hard.
them being able
Steph
to
Yeah, like we
down
can
in
get
a
about
timely
3,
manner.
like, because we wanted to start early so they could get like kind of 3-ish patients ready. So we tried to flag like, okay, when the people show up at the hospital, we can't, you know, but it's like, okay, look for these people. They're the ones we really want to get the shoulder, if it's a knee, you know, we've identified.
They wanted those blocks in, and they were told ahead of time to come in 3 hours instead of 2. So when you have surgery, you're always here 2 hours ahead.
Yeah.
These guys were told
Yeah.
3, and Steph still found that
Yep.
there were some people that unfortunately didn't get prepped, and I don't know if she did it, but that was a little hard.
another piece of it. And again, it's showing that like it makes sense to spend some money out there.
We need to.
Just like it makes sense to spend money on
spend it out
physio.
there.
Yeah.
There was
'Cause that shouldn't be a bottleneck.
bypassing us completely, and I'm like, we can't go there because
Oh, that
they're a
would
big
break
problem.
them.
Yeah,
that would,
we would be
that
happy
would
to
break
do
them.
that, but if it's gonna like, this is sort of thing like this could be a benefit. However, not right now.
No, that's right.
It would be.
Going forward,
right.
though,
Yeah.
if
Yep.
we fix them a
Yep.
bit better.
Yes.
Yeah,
Right?
but they've had no funding. Like they've built all this new area, and
Yes.
then they've opened up 12 more
I know. And
daycare
no new
beds,
staff.
and no new staff,
Yeah.
and no funding at
And
all.
more
That's-
patients.
So
Yeah.
it's
These
just
are good.
brutal.
So
for
are
them
there
right
things
now.
that we can maybe highlight
Yeah.
and I think Chad is actually trying to work on
He is.
that.
He's on
Separate
the
the
Yeah, he's been
Yes.
very supportive of this process,
Yes.
including the bigger picture of like, okay, how does this change? Well, these sorts of things.
Yeah.
Yeah.
Yeah, so
Um,
I think it's going to be
The other
really
hope is
good.
that that person would be a resource for a lot of the low blood pressures, blood sugar, high blood pressure. You know, if they're not frantic in the morning, like you see, we hit a lull. There are times where
Yeah.
so it's like
Yeah, you're really
there's a
busy in the
doc
morning.
right there. So if they're not busy, maybe they could.
Well, the one
know.
day it was great because we had issues on 16,
Morning.
and then what happened was, I don't know which anesthetist we had, but the anesthetist that brought the patient out chatted with whichever
Yes,
anesthetist,
yes.
and it was perfect. So,
Do you mind? Yeah.
and you know what?
If
It was
further
Yeah, that was good.
down
That was
the
good, yeah.
line we have your anaesthetic staff, is there a plan to create a roaming position?
I brought it
like a
up
roamer?
yesterday.
Because I've
And
worked
I
in
heard
hospitals
everybody
that
Yeah,
have that,
yeah.
and they're very
So
beneficial,
It's all
especially
going to
for
be
PAR.
fixed by
Yeah,
today.
yeah.
Who's working on
That's if we find ourselves with more of us, that's absolutely a use. Yeah, because
Okay.
the other thing the roamers can do are things like sedations and MRI, which I know the peds wants to do sedated MRIs, and they need.
Right.
It's like, okay, I would love to. It's not that I don't want to help you. I just don't. I would have so
Well,
many.
no,
questions.
this is hard
But
to know.
absolutely.
But when we get more
Especially with an
anesthesiologists,
AA and anesthesiologist and roamer,
so
they can help out in
good.
clinic, they can help out here, they can help out. So yes,
Awesome.
the short answer is absolutely. If I could hire like
But we
10
need
more
more
anesthesiologists, yeah. I was at a meeting and everyone said the same thing, which is we need a tree that grows physiotherapists,
Anesthetists.
pharmacists, and
Yeah,
anesthesia,
we do.
emerge docs,
Yeah.
hospitalists. We need a
Yes.
hospitalist tree.
Yeah, we need family.
Oh my God, I don't even
Yes,
have a doctor.
people to work in the clinics or the nursing homes, coverage the nursing home patients.
Right, right.
It's just.
Well, Scott, this was awesome.
Yeah.
Yeah, thanks, guys.
You know, like we
Sorry, I didn't have
super-
a
No,
slides,
no,
but
it's all
No,
good.
if
That
you have
was
questions-
awesome.
We super
yeah,
appreciate
yeah,
this.
okay.
Because we can, and if these guys think of any ongoing
Yeah.
questions, maybe I'll just have a sheet up there
Yes.
and we can just randomly
Yeah,
ask
yes.
Well, one
And I
question,
think-
Scott. Is there any risk of the patient squeezing that bottle? And
No, so I should have problem too. It's hard.
Yeah, it's hard,
There's basically
yeah.
almost nothing you can do to increase or
okay,
decrease.
okay.
Height can change it by 1 or 2%. So if you
Okay,
put
so
up
it's
really
not-
high gravity a little bit, they suggest that you not warm the bottles, but that's like don't put them in a hot tub. Don't climb in a hot tub
okay.
and float your bottle beside you. So it's a significant. It's not like fire. Like
That's a
I
different kind
keep
of
my house at
hobby.
82 degrees. That's not gonna.
No, it's
it's
not
a
good.
big. Yeah, don't boil it. Don't freeze. Don't go lay in the snow.
Right.
Oh, I guess one thing was to keep it. So if you're doing the cryo, don't tuck the bottle under the. I don't know
yeah.
why you would, but these are the things they say.
We're
Don't
dealing with humans.
Yeah, that's what I
yes.
was thinking.
People-
yeah. Do crazy things.
And then the other question I get a lot is, I'm doing this and the block, so I'm not taking any other medication. And it kind of hurts a little. I'm like, no.
Take
Tylenol.
Tylenol,
You're
right.
supposed to be like.
Yes.
So even though they're told, and they
adjuncts.
give it to that point about like 25% of,
Yeah.
they're given instructions, and we tell them. I call them, and there's still people who I call and say, no, take acetaminophen and take.
Right.
And they're like, oh yeah, that helped. That,
Tylenol, I'm telling you
NSAIDs.
guys,
Yeah.
we need IV Tylenol.
We have it. We
we
have
have
it.
it. We do have
We
it.
have it.
Why don't we use it?
I think the cost of it. Yeah.
So one of the things when we did that block through,
Yeah.
5 North was kind of a little bit grumbly, just that their protocol with the hips and the knees is to get them from the stretcher to the bed.
Sorry, we're doing
Right.
And so they said, oh, I can't ambulate right now. Is there something we could do here in order to like test the block without, because we don't really get them up out of the stretcher yet?
Yes. So
You know what I mean?
to be honest, they should be the ones testing, which is the sit on the edge of the bed, either a walker, like because we're doing motor sparing blocks, but you just want to be sure. And it's even if we don't do a block, when you have a painful joint, so after surgery, hip or knee, you lose 50% of muscle strength just immediately. It's from pain. It's not cutting the muscles because it comes back the next day as the pain level goes down. So they should be doing the exact same thing with the blocks as the non-blocks, which is, get them up slow. Make sure, can you feel the ground under your foot? Okay, first couple steps, this is where and then you're good. And if they go and they're, no, okay, sit back down. We're not, exactly. But we're doing motor sparing for that reason. Like the femoral nerve blocks for sure take out the quad, so we generally don't do those unless they're not going to ambulate. You know, but they've had a spinal too, so yeah.
Well, because that was a spinal. So I'm like, oh, the spinal's worn off.
But make sure, let's just make sure. Yeah.
Cool.
Yeah. It's a great question.
Yeah.
There you go.
Yeah, see ya. Yeah. And it's appropriate. Like,
Sometimes the feeling left, I think what this is reflecting is that on 5 North, I think sometimes they're feeling left out of the loop.
yeah.
Right? They feel like they're not getting, and the communication can come from us to that one nurse, but then it gets lost.
That's the piece that I was surprised to discover, because like when we hand over, we tell each person down the line, but
you can tell me,
Yes.
I can tell her, she can tell her,
Yeah.
but
it doesn't.
But by the time it gets to solstice, what
Right.
you told me
It's
is only
telephone,
half of
right?
it got
That's
to
right,
yeah,
solstice.
yeah.
Whereas
Fair.
if you do the message to nursing exactly what you
Yeah. And it's short, right? It's just this person has had a block, ambulatory
Yeah.
care,
Yep.
or,
Yep.
or
Well,
if
you-
pain issues, call anesthesia, don't call surgeon, call us first. Call
Yeah.
anesthesia
Yeah.
on call, they'll reach out to
Yeah.
whoever.
or even just that it is, it's muscle sparing, or
Yes. Yeah.
however you
Yeah.
want to phrase it,
Yeah.
so that nurse knows,
Yeah.
and then the
First few
next
steps.
nurse knows
Yeah.
as well. Because I think they're so short and busy on the floors now
Yeah, that makes
that
sense.
that face-to-face report doesn't occur a lot.
Yeah.
They're depending on what's written in their computers.
Right.
So maybe we should be getting their educator up to speed on the floor, and then they can
Yes,
pass
but
out all that
again, it's
education.
a
5
matter
North
of
and
that
6 South,
educator
right, would be the
speaking
two.
to them.
I would say.
Yeah, because I gave her
Isn't
that
that their
information.
job?
Yeah.
I've given her the information.
Yeah.
We don't really do them on trial lists.
I don't know if there's a time like this
It's
that
mainly
Jason
just
or I or somebody can
5
speak to them, but.
North, right?
Right,
That we would
okay,
need
yeah.
that for.
And 6 South too, right?
She's the same.
Yeah.
Same.
Same. Oh, it's the same educator?
educator.
Oh, good.
Five North, six
Because
South.
that's been my confusion. It's like, okay, there's 2 actual floors, 2 different
Right,
places.
Yeah, same educator, different managers, but
Yeah,
same
yeah.
educator.
Maybe I'll get
But
in touch with
utilizing
their
that message
educator.
to
You
nursing,
could
I
actually-
think,
I've given her
That's a
all
great
the
idea.
I think
information.
you
Probably
guys
do
will
it
find
better
that
as
it
your-
really
Yeah,
will
I can
help.
talk to
Yeah,
her.
that's
Especially as you go towards trying to get that standardization.
Yeah.
You're years,
Oh, yes.
realistically,
Yeah. Yep.
before you'll get to that end.
You make big gains once you have a proper service, and that was some of the feedback too. We guys, well, why did we start this without a proper service? Like, well, this is how you pilot.
I was
Yeah.
gonna say,
Yeah.
you
Yeah.
have
You have to
prove
trial
need
it.
the
Yeah.
service
Yes, we're
before
building
you
a
get
car.
it.
We can't start at the stage
No.
the car is built. We're
Yeah.
actually having to,
From scratch,
whatever,
right? Yeah.
They're not
salvage
going to
your,
give you
yeah.
funding unless you prove you need it.
yeah, and gotta do things in a little and learn, because we don't know the perfect way, so we have to
That's
kind of
right.
learn how to do it here. But
Yeah.
thanks, guys. Appreciate the
No, that was awesome.
The
Thank you.
feedback,
Yeah,
the-
thank you.
information for
That
me.
was awesome.
Okay,
Right
can
on.
I question you